Okay, you're good to go.
Okay, all right. Well, good morning, everybody. This is, or actually afternoon. This is Sandra Dawson, and I am the East Coast Pharmacy Manager, they call it Pharmacy Services Manager, East Region with InnovAge PACE. And I'm going to talk to you about falls today. And I am just going to go ahead and put this up. I hope you'll be able to see it. You tell me if you can.
You're good.
Okay, great. And I hope this will let me click it. Yes, and I've got to find out. So the first thing I'm just going to tell you about the fall facts and the risk factors of falls. And we're really with the focus on medications and their safety and how their effects does create falls in the elderly, and ways that we can kind of determine whether or not a fall could actually be caused by that, because they really do have a big impact. The medications have a big impact, and we don't think about it. First of all, just wanted to say it's a good time of the year, because since September is Healthy Aging Month, or I actually skipped, I think. No, that's right. I'm sorry. So September is Healthy Aging Month, and it's a World Physical Therapy Day. It's the September 8th, and then the National Rehab Day. So just a good month to be talking about this. So I love this. I think this is pretty funny. I don't care how old as I get, I feel like I'm just as spry as the youngsters, but I do think this is a quite comical little comic that you see here. And I know you all probably know a lot about the facts, but older adults, truly, there are about 36 million falls every year, and there are about 32,000 deaths per year because of falls. 95% of the hip fractures are caused by falls, and those are what are usually lead to death in our elderly, honestly, which is so scary. But we also have to talk about head trauma and broken bones with these falls, and about 1 in 5 falls has some sort of injury, like a broken bone or a head injury, which is pretty remarkable. And of course, there are tons of hospitalizations. And for some reason, we all seem to think, oh, this is something normally that happens, but it's not really a normal part of aging. Falling is not supposed to be a part of aging. So there are lots of risk factors, as we know, everything from mobility and balance and strength and incontinence, and people are running to the bathroom. They have, numbing in their feet, things like that. But I'm really going to focus on taking 4 or more medications, because taking 4 or more medications in someone who's over the age of 65 is a really big risk factor for falls. When we have people that we are worried about or thinking about, and I think I have not skipped here. I think I have not. Yes, sorry about that. I'm going to focus on the medications. There are lots of ways you can check for risks for falls, and you can talk to people, but I will tell you that just asking somebody, hey, how many medications do you take? Do any of them ever make you feel funny? Do you feel lightheaded? Do you take anything that helps you sleep? Things like that will give you a really good indicator of how people are feeling or doing. Or do you ever feel drowsy in the morning? Just some of the common questions you would think about asking someone. And it's amazing what you can find out. Here's another little funny. And I hope I didn't go by that too fast, because I do think that some of these are just so wonderful. But I'm going to tell you about some of the risk factors. First of all, as we age, we have decreased eyesight. That doesn't mean that everybody's going to get a macular degeneration, but there is decreased eyesight. Cataracts, there are tons of different things that can occur. But also liver and kidney function do not work as well. So drugs that are metabolized in someone who's 25 are going to be accumulating in an older person's body. They're not going to be excreted or metabolized as quickly. And so that's another concern. So some of these drugs build up over time. Excuse me. And then the muscle, of course, where there's less muscle and bone density is less. So therefore, definitely it adds to possible problems with falls. And then, of course, all of the multiple disease states our elderly have. So this is something we need to definitely look about and think about as well. So I don't know if you've ever seen the Dr. Seuss about the polypharmacy, but it's really quite cute. It goes, I'll see if I can't read it to you because it's a little hard to read. But this small white pill is what I munch at breakfast and right after lunch. I take the pill that's Kelly Green before each meal and in between. These Loganberry colored pills I take for early morning chills. I take pills with zebra stripes to cure my early evening gripes. These orange tinted ones, of course, I take to cure my Charlie horse. I take these blue in 8:30 to slow my exhalation rate. On alternate nights at 9 p.m., I swallow pinkies, 4 of them, the red ones, which make my eyebrows strong. I eat like popcorn all day long. The speckled brown are what I keep beside my bed to help me sleep. This long flat one is what I take if I should die before I wake. I just think that's really quite comical. So here are some of the major ones that are cause problems in the elderly. The anticholinergics, the alpha-1 blockers, the benzodiazepines, opioids, antidepressants, and antipsychotics. Now there are a lot of these certain groups of these medications are actually on a list, what we call the Beers list. And the Beers list is drugs that potentially can be not appropriate for our elderly patients. So that is something that we really want to be thinking about, especially prescribers need to be thinking about when they're prescribing. And we'll talk about these. The Beers criteria, just so you know, is made available by the American Geriatric Society, and it really is a guide for our providers to use in the industry to help them make good choices, safe choices for our elderly. And if you have any questions about these different categories, I certainly can tell you, but most of these, like anticholinergic medications, they block nerve impulse control functions like salivation and digestion. But an anticholinergic, you might know, is Benadryl. So it kind of makes sense. So just to give you an idea of what some of these will do, I can also tell you, like alpha-1 blockers are more like heart medications. Benzodiazepines, you probably know as anti-anxieties, the ones that kind of calm people down. And all of these different ways, I was going to go into some of the pathways, but I don't think I necessarily need to do that unless anybody's curious. So, but I will go through it a little bit. Okay. And so once I was talking to you about the prudent prescribing, which medications increase the risk for falls, this is something that providers learn about and hopefully look at a lot to make sure that we are making sure we're decreasing that possibility of the falls. Diuretics, of course, people are running to the bathroom, and so that definitely makes an increase in falls possible. Sleeping pills, a lot of people, once again, they don't metabolize as well, and these medications build up in the participants' bodies, the patients' bodies, and it definitely increases risks. Antipsychotics, epileptics, antidepressants, of course, opioids, and then a combination of a lot of different medications with small side effects can make a big difference. So we also want to make sure we're being careful of those. So the psychoactive medications are another, what we were just talking about. These are the antidepressants, the benzodiazepines, and the antipsychotics. So you can see all the different side effects. Like the antidepressants, some of the, especially the older ones, they cause sedation. They have the anticholinergic side effects, or dry mouth, dry eyes, and then orthostatic hypertension, which can lead to falls. The benzodiazepines really affect cognitive impairment, make people confused. Obviously, there's also a risk of stroke and dementia patients that has been known. And antipsychotics, they definitely have an anticholinergic side effect and also sedation. And here we were talking about that anticholinergic, the confusion, the dry mouth, also vision problems, just even with the dry eyes, but even more pronounced. And then the blood pressure lowering agents, which really can cause you, the orthostatic, they get up too fast, they don't wiggle. I always tell everybody to wiggle before you actually get out of bed, or before you stand up, pick your legs up, march in place for a second, do something so it kind of gets your blood pressure going, because a lot of them stand up and then immediately or fall down. There are a lot of anticholinergics that are used for Parkinson's disease, overactive bladder, irritable bowel, COPD. So there are so many of these unintentional anticholinergic side effects that are really difficult to work with. Let's see. Okay, so what can we do to help our participants? Well, we know, and we have a lot of different providers and people out there, physical therapists, et cetera, helping wear proper footwear, make sure that they're looking at people where they live, and if they're removing all the hazards, making sure things are well lit, making sure they're exercising, they're checking all their durable medical equipment. But we also want to tell everybody, all of the participants, to report anytime, one, they fall or have a near fall. They report any adverse side effects they have to medications, whether it is they are sleepy in the morning, they feel like drowsy, or they have that hangover effect of a medication, or it makes them dizzy right after they take it, but to let us know. And then they also need to be asking their providers about all their over-the-counter meds they're using. And we'll talk about some examples of this. So there was a 75-year-old lady living independently in an apartment building, and she fell while she was walking with her grandchildren, going to dinner in a parking lot. She'd been recently started on a muscle relaxer called Robaxin. Another thing that you can really, whoops, I didn't mean to do that. When somebody is on a new medication and then they have a near miss or a fall, and they report a side effect, that's a really big indicator. Like, this is something we really want to talk about, we want to think about, because starting the new medications right there is almost a risk factor, because we don't know how it will affect somebody. So that's a good thing to think about when you're talking to people. And then another good one, and then Robaxin also has a lot of the sedative side effects as well. So you just starting and even stopping medications, there are a lot of antidepressants that people will stop, and instead of tapering, and even during the tapering process or titration process, I'm not sure I do have another example of that is also a good time for people to fall. But we have an 80-year-old female living in her home, and she had 2 falls and 1 close call, and her daughter caught her in the morning during a 2.5-week time period. After a paid staff investigated and discovered the daughter had been giving her mother Tylenol PM every night because her mom wasn't sleeping well. Well, unfortunately, Tylenol PM has Benadryl in it, or diphenhydramine in it, which is one of the anticholinergics. And everybody thinks Tylenol and like Advil PM, they're just, they're just a really great way to try to fall asleep. And it's not it's not a real, medication, but that is really not true. Benadryl is one of the major causes of falls. So we really have to warn people. You don't realize what's in some of the OTCs until you really look, or just talk to a provider or your pharmacist. We have a 70-year-old man who was prescribed Zyprexa ODT, and it was at 5 milligram strength, and the provider wanted him to take half a tablet at bedtime. Although the participant usually took the Zyprexa 2.5, an on-call provider was contacted because, oh, excuse me, I better tell you this, the ODT formulation is orally dissolving tablet. So they just can put it on their tongue and it will dissolve. So because one prescriber asked for the ODT, the on-call person didn't want to change it. And so he said, it's okay, even though you can't cut an ODT in half, just go ahead and give them a whole tablet. Well, unfortunately, that person fell while taking that medication because it was double the dose. And it doesn't seem like it, since that's the lowest strength an ODT tablet comes in. But if he wasn't used to it, once again, titrating, starting up or taking down, there's a lot of risk for falls. And the last one, an 82-year-old female was prescribed Lyrica, which is for nerve pain, due to her diabetes. And every time there was a dose increase, like Lyrica and gabapentin's another one that you can increase, and it goes up a certain amount of time, every 2 weeks or every week, whatever the doctor decides is best for them. But they do just that during the titration periods, every time they fell. And it was 3 times. And it's just so frustrating. You almost don't even want to try to increase it, but everybody's on high alert. At least they will know that this is a potential for them. So we do coordinate. We all, at PACE, we all coordinate our PACE teams. We have providers, physical therapists, occupational therapists, nursing, aides, pharmacists, and we discuss all the possible risk factors that could be playing a role in someone who's falling. And we collectively try to make recommendations to the provider in hopes to decrease the risk for falls. But it is amazing. I'd say many times when you get a group of people who all know a person well, and they say, well, they have a cat, because they always seem to be, the cat's always under their feet, or they always want to try the latest, greatest OTC, things like that. We can usually figure out some of what has played into the role of that fall. So it's very interesting, because once we all get together, you usually can find out what's happening. And so I will pass this on. So thank you so much. Does anybody have any questions?
I have a question for that may help some of our members on the call. So our members are not clinical in nature, like they're not expected to know all of the pharmaceutical terms and things like that, but they do obviously have the closest contact with the residents and sort of recognize when changes are happening, or a resident may indicate that they've fallen, or there may be bruising and things that the service coordinator sees and asks, like, what happened? So knowing that they don't have all this medical background, what are some things that they could ask the resident that would maybe let them know that they need to either like request a med review, or what are some of the signs that should be reported, I guess, to a healthcare provider, or if it's a home health aide or whomever is coming into the residents' lives to help them?
Gotcha. Okay. I really think some of those good questions are, and hang on, I'm going to pull this up a second. I'm going to stop presenting, and can you all still see my screen?
No, we see you.
Okay, good. Okay. I was going to tell you there are, like, if they're just, you can ask them how many medications, if it's not too personal, how many medications, do any of them make you feel dizzy? Any of them make you feel drowsy? Do you talk to your pharmacist our doctor before you take OTC. Some of those things are, I think, helpful. And, you know, are there any medications that make you want to hold on to furniture after you stand up? Things like that can be helpful. And I really, there are just so many good ways to go about asking people about their medications and how they make them feel. So I don't know if anybody has a good suggestion, please let us know.
So for any of our service coordinators on the call, I don't know if you have anything that you want to add to this, or if you have maybe a specific example you'd like to share, but there is a microphone button. If you click unmute, you would be able to talk, or if you don't have a microphone on your computer, you could always chat in using the chat button at the bottom of the screen.
Okay.
Awesome.
Well, I will pass this off then. Thank you so much, you all.
Thank you.
And I'm just going to go ahead and get started from my section now. So excuse me. Can everyone see my screen?
Yes.
Yes.
All right, awesome, awesome. So just a little bit, I'm not sure of locations for everyone, Nina, but nationally we are known as PACE, so Program of All-Inclusive Care for the Elderly. But in Pennsylvania specifically, just due to some other programs, we're known as LIFE, which is Living Independently for the Elderly, so that you guys can see that. So what is PACE? InnovAge PACE is a program of all-inclusive care for the elderly, or LIFE as Living Independently for the Elderly. We help seniors live life independently for as long as possible. And our mission is to sustain and enhance the independence and quality of life on their terms for those we serve. And then the mission for us also is to allow is to allow seniors to live life on their terms by aging in place in their own homes and communities for as long as possible. That is especially important for us when we're talking about individuals who are receiving different types of care. They have different environments that they might be used to. So we're trying to make them as comfortable as possible. So what is PACE or LIFE? So there are 272 centers in the US that encompass PACE or LIFE. Centers for PACE are actually in 31 different states. So individuals always ask, where are they located? So that's just a little bit more specific about it. There are over 55,000 adults that are on the program. And just a little bit more into the kind of the program, because this always comes up as, what is PACE? Are you guys a center? Are you guys a provider? So we're a little bit of everything. We have centers, we service individuals for their resources, healthcare resources. But the biggest thing is we're trying to be an inclusive model. So we're trying to provide everything to the individual. But it is something that is for long. It's not something that, you get on the program and you're done within 3 months or 4 months. This is something that surrounds individuals within their homes for a very long time. And that's the basic model of how we last. People often say, oh, you're a center, but it's a lot more than that. And I'm sure Sandra will agree with me on that. So what you're going to find on the screen are just pictures of the facility, just to be specific for you all. So on the top left and the top right, you're going to see what our centers look like. And those are typical activity rooms. Individuals might come to congregate. They might come for meals. So we like to call those community rooms for individuals to enjoy different types of things that they can do within the center. You'll notice in the bottom left corner and right next to that will be one of our offices. So it's typically set up just like an office for you or I to go to the doctor. Some people might come to the center just for their appointment. Some might come for some of those activities that I talked about. Some might come for therapy. Some might come for everything. So it just varies on what they're coming to the center for. And then on the bottom right, what you're going to see is a dental office. So within the dental office, individuals within our program, and I'll explain a little bit more deeply shortly, but they're able to receive different types of dental care under the PACE or LIFE model. So things such as like fillings, individuals getting cleanings, cavities, getting dentures, those are all a part of the PACE or LIFE program, which is why we talk about trying to provide that all-inclusive care model. So here is our interdisciplinary team. This is more of a visual so you guys can see. And what does that consist of? And it consists of a little bit more than this, but the main interdisciplinary team includes the primary care physician, registered nurse, social worker, physical therapist, occupational therapist, rec therapist, a center director, dietitian, our PACE day room supervisor, our life specialists, as they might be known, home health coordinator, and transportation driver. All of these individuals, as you can see, are circled around the participant and what care is important to them. We really try to focus on their needs. We try to focus on everything that might change. We do involve other disciplines as well, but typically this is what you're going to see from our IDT team. What does center care mean for us? So a lot of people always ask, what are some of the services you guys provide? As you can see, here's a whole realm of services that we provide, again, centered all around the individual. So things like primary care. If individuals need telehealth, we also provide that. Any post-acute care. So if they're, going into skilled nursing facilities, we have a contracted network that we work with specifically. Any type of specialist they might be receiving. And that includes like cardiology, podiatry, anything you guys can kind of think of that might be useful for the individual. Any unskilled care. So what does that mean? Unskilled care might mean somebody might need help with just, getting up around their house. Somebody might just need assistance around the home. That might not include a actual therapy, or it might not include, this is something that was recommended, but this is what we're checking on their care plan. We're consistently observing the changes. We're noticing they might need help with bathing, dressing, things that help with their ADLs or IADLs, things that are important when you guys are dealing with people in their homes. We talk about pharmacy, obviously, Sandra covered that. But it's very important that we're sending this medication to individuals. We're making sure they don't have co-pays, things that are important to them. Dentistry, which I just spoke about, but that's inclusive of the program, and therapies. What's nice about our therapy model that is very different around everything else that people might be receiving is that it's not capped, which means we can spend as much as amount of time with an individual that we need to. And that's really, really important for us, because as long as they're progressing, we're not just cutting them off. We're trying to make sure that they're healthy in their home environment. And then this is just another visual that you can see some of the activities, again, that we provide. So vision, didn't talk much about that, but we make sure that they are provided any of their vision needs. Hearing aids, things that are really important to that whole individual. And that's why the PACE program is such a unique model. And that's why we talk about eligibility and things like that, because we are really providing everything. So what does it look like to be eligible? Typically, you have to be 55 or older. So we've had individuals who are 54 and 11 months who show interest in the program. That's okay. We can start them getting them in the process, but they cannot enroll until they're 55. They have to live within our zip code, our catchment area. So making sure that we are providing them that. They can remain safe in the community. So that's important to us, because obviously, although we are modeled to support the individual, it does not mean that they will have somebody with them 24/7. So that's important to us. And the participant has to meet the state's skilled nursing facility level of care requirements. So that changes per state. If there's specifics or certain individuals who want those specifics, we can definitely provide those to you too as well. So we enroll on the first of the month. We help with all of the paperwork because it's always a question, you know, who's going to help, who's going to assist. There's so many different payment paths to this. So people can have dual Medicaid and Medicare, people can have Medicaid only, people can have Medicare only. That goes into kind of our self-pay option. People can have other insurance plans, and then we'd have to evaluate and look because there is a financial requirement, and that again changes per state. So we want to make sure that we're following all those guidelines. But the most important parts for you guys are that they're 55 or older and they live within our service area, after which we will start to evaluate the rest to make sure that they're eligible and things like that. Every state does have different requirements too as well regarding, you know, what makes them eligible. And again, those are things that we always talk about and look at. But the biggest thing is, does somebody need assistance? Is there somebody that really could use the program? Is there somebody that could use the support? And how can we help? This is the biggest thing. We can help stabilize your residents. We can help with hospitalization prevention. So making sure they're not going to the hospital, because we're monitoring them more frequently. They're coming to the centers, you know, center visits. So we're really observing them. We're seeing, hey, you might notice Mr. Smith might be struggling. Isolation prevention, you know, we're trying to engage them. Transportation to all medical appointments, transportation to the center. They don't have to worry about who's going to take them, making sure they're actually going to their appointments. Services all under one roof. Obviously skilled nursing avoidance as much as we can. They have a case manager with them, so we're observing them consistently. We're helping coordinate all their healthcare, and we're helping the resident when they need higher level of care. Those are our biggest things. And with that being said, that is my last slide, Nina.
Wonderful, thank you. Does anyone on the call have any questions or comments for Sandra or Justin? All right, well, I don't see anybody unmuting or chatting, so I'm gonna assume that there are no questions at this time. If you guys think of any questions or would like additional information, you can reach out to me and I can connect you with either Justin or Sandra for more information. But thank you all for your time, and thank you, Justin and Sandra, for taking the time to present today. We appreciate it.
Absolutely, and I will provide that feedback as well to Leslie, and we'll make sure that, you know, you guys have the information. Nina, I know I've sent the slides over, but we can still always provide more information to you guys to make sure you feel supported.
Definitely, thank you. It looks like Deb unmuted. Do you have a question, Deb?
No, I just wanted to say thank you.
Wonderful, thank you.
Thank you. You all have a wonderful day.
Thanks, you too.
Bye-bye.
Bye.